Hi, everyone. I think we'll go ahead and get started now. Thank you all for joining today's GORCOP webinar, which is part 2 of a 3-part series on interpreting quantitative G6PD test results at the point of care. 2 weeks ago, we hosted part 1 of the series, and today we're going to continue the conversation as we hear from Pooja Bansil and Emily Gerth-Guyette on numerical quantitative test results interpretation with the focus on the SD Biosensor Standard G6PD Test. So I'm just going to start us out with some brief GORCOP information. We'll get into the presentation, and then at the end we'll have time for Q&A, both from the broader group as well as some focus questions that came out of a recent survey we distributed on experiences with test results interpretation. So for those who may be new to the GORCOP, I just wanted to give a quick background. The GORCOP is a collaboration of researchers, organizations, malaria control programs, and clinicians committed to advancing the introduction and scale-up of G6PD diagnostics in support of safe access to radical cure treatment for P-Vivax through operations research. The group aims to harness best practices and lessons learned from various stakeholders and benefits from the expertise of participants in areas such as diagnostic introduction, operations research, implementation science, quality assurance, and training. To support information sharing, the GORCOP maintains an online repository of resources that is accessible to all participants. We host meetings and presentations like this webinar series, work to provide relevant updates, and help create connections among our participants. So we do have a website which you can visit at the link you are seeing on the screen now. You'll be able to see some additional information about the GORCOP. We have available resources and past webinar recordings on there, and you can also find the link to sign up to become a member if you are not already one. So if you have any questions on that, feel free to follow up. But with that, I will pass it over to our moderator for today, Abhijit Sharma from PATH, who will introduce our 2 speakers and get us into the presentation. Over to you, Abhijit.
Thanks, Amanda. So hello and welcome everyone. And thank you for joining us in today's GORCOP webinar part 2, which is on interpreting numerical quantitative G6PD test results at the point of care, why and how. To give a brief introduction about myself, I am Abhijit Sharma, Senior Program Officer at PATH India office. And before we get started, just a little housekeeping. If you have any question during the presentation, please click on the raise hand options or type them in the question or comment box. Now, without further ado, I will turn the time over to Emily and Pooja, the speakers for today's presentation. Pooja Bansil is a public health researcher with experience designing research studies and conducting statistical analysis. She currently serves as a technical officer for the diagnostic program at PATH, where she primarily leads or supports the development of data collection tools, data management, analysis, and interpretation of data. Emily Gerth-Guyette is a public health researcher with over 10 years of diverse experience in research and program management focused on the development and introduction of global health technologies. She currently works as a program officer with PATH's Global Diagnostic Program, where she leads and supports clinical and user research for diagnostic products, including evaluations of diagnostics for performance, usability, and operational feasibility. So with this, I'm passing it to you, Emily.
Thank you so much, Abhijit. Yeah, thanks everyone for joining today. We're really looking forward to talking a bit more about the standard test, and I think just really want this to be a really pragmatic overview of what we know and sort of trying to address some of the challenges that you have all raised in interpreting the test results and what it means for clinical practice. So just as a brief overview of the presentation, I'll start with an introduction to G6PD testing and the standard test, and then Pooja will use some of the data that PATH has generated over the past few years to answer some specific questions about how the quantitative thresholds align with the case definitions and G6PD activity distribution. what we know about the precision of the test at the point of care, some questions around the need to establish site-specific thresholds for classification of G6PD status. And then finally, some data we have around the test results that indicate males testing in this intermediate status. And then we'll close with finally the really exploring and understanding the clinical implications of this semi-quantitative test and test performance. And then we'll move on to some questions and answers from the group. Next slide. Great. So, you know, I think we all know G6PD is an enzyme that everybody has in their bodies, and it's, you know, important for red blood cells and our ability to respond to oxidative stress, which can be triggered by taking certain medications. In this case, you know, we're going to talk a lot about G6PD testing in the context of malaria case management, so such as primaquine or tafenoquine. And I think that, you know, in terms of interpreting the test result, what we're really trying to get to is that this G6PD status can be classified as deficient, intermediate, or normal. But that's really kind of drawing some lines in this, you know, range where someone can have a mix of normal and deficient cells on a spectrum, and that aligns, you know, more or less with the genotypes that you see above. Next slide. Yes, we know that this status, this classification is relevant for malaria case management, and that the recommendations for giving or not giving primaquine really depend on this classification. And so this table shows a summary of the WHO malaria treatment guidelines for Vivax radical cure, kind of a summary of them both from the 2015 guidelines and then the more recent update. And what you can see, sort of starting with the G6PD, people who are classified as G6PD normal, you know, they can be treated with a 14-day course, a sort of standard course of primaquine in all transmission settings. For deficient patients, there's an alternative course available. They're ineligible for the 14-day course, but can get weekly primaquine with medical supervision. And I think, you know, the actual implementation of this is problematic. There are, you know, a lot more logistical and adherence issues when you're talking about such a long course of primaquine. And then for intermediate females, they're eligible for primaquine, you know, with some additional counseling on how to recognize the signs and symptoms of hemolytic anemia, because there is some risk involved. When G6PD status is unknown or testing is unavailable, the decision to prescribe primaquine is based on an assessment of risk and benefits, and, you know, really kind of more at an individual provider level. And those risks and benefits are outlined below. So consideration of, you know, what the relapse rates are in that area, the incidence rates, how prevalent G6PD deficiency is in the area, and then a consideration of the patient's ability to identify signs and symptoms of hemolysis and access healthcare if need be. So a lot of those risks are really subjective, and providers may not have full information when they're trying to make these decisions. So having a G6PD test to classify someone at the point of care really, I think, you know, obviously facilitates better use of primaquine. Next slide. And so there are multiple ways, multiple testing platforms for G6PD classification. And there's obviously genotyping, and I'm going to focus a bit more on the enzyme activity measurement. So starting at the top, and these are kind of aligned based on where you might expect to find this type of test. So a quantitative test, you know, would likely be only available in a high throughput laboratory, maybe at a national reference center. In that middle level, we've put both the fluorescent spot test, which is currently in use, and biosensors kind of bridge both the district and sub-district hospital level and the community levels, which are starting to be used more. And then the very bottom level are the rapid diagnostic tests, the lateral flow cassettes. And with each of these testing platforms, you need to go through a process to turn the test result into a G6PD classification that can be used for clinical decision making. And I think each of those platforms, has certain challenges. Next slide. So for the quantitative test, there's a need to really establish a reference range, preferably a local reference range, and establish thresholds for results that fall within that range and outside of that range. And so you really, you need access to a lot of samples, and you need sort of high technical capacity to be able to establish that in any given setting. And then you run a patient sample, and then you compare the result you got to the reference range that was established, and then and only then can you sort of determine what someone's G6PD classification would be. Next slide. The lateral flow rapid tests, the test output is this presence or absence of a line, which is much easier to interpret. But I think, we're aware of the limitations of these types of tests, particularly for women, as the test cannot be used reliably among women. The tests are more able to distinguish between severe and non-severe deficiency, and they also have some operational challenges around temperature and other types of field conditions. Next slide. So the biosensor test that we're going to talk about today, the SD Biosensor Standard Test, it's a quantitative test with a semi-quantitative interpretation. And I've just put an image of the test here and the workflow for people who aren't familiar with it. Next slide. These are some of the relevant intended use statements from the most recent SD Biosensor Standard G6PD Test label. So this test is intended for the semi-quantitative measurement of both G6PD activity and hemoglobin in capillary and whole venous blood. And the test is able to differentiate between normal, intermediate, and deficient G6PD activity levels. The test also gives a result of total hemoglobin concentration in grams per deciliter. And this is used primarily to determine G6PD status, but should be confirmed or used cautiously when used for monitoring disease progression or making any decisions about maybe treating anemia or not treating anemia. So that's not the primary use of the hemoglobin result in this case. It's mostly to help determine the G6PD status. Next slide. And so in this label, SD Biosensor has provided the thresholds to apply when determining the classification of patient samples according to this test. So rather than having to establish your own ranges or relying on a test line, you would run the test, get a result, and then compare it against the numbers contained within these tables. And the numbers here were generated and validated through clinical evaluations, and they represent 30 and 70% of the adjusted meal median. Next slide. So we have been developing materials to sort of support the use of this test in the field, and wanted to take a moment to highlight a new resource that we've developed based on some feedback around how the the ranges and the sort of specific cutoff points and greater and less than symbols are not always the most intuitive for people to use. And so this job aid kind of lays out more clearly a couple different things. One, that the thresholds should be applied differently for males and females, with females having that yellow intermediate range to be considered. And it also indicates, if you look at the far ends of the bars, indicates when the test result will read as either high or low. So particularly when you get a result above 20. And then just to flag some of the warning messages on the test around the interpretation of the hemoglobin results as well. So our goal is that as we get more feedback about the use of the test and what materials are needed, we can keep iterating on them. But hopefully this will be useful for for people who are training on the use of this test and particularly working at lower levels of the health system. Next slide. Yeah, so with that, I'll hand it over to Pooja to talk a little bit about those 4 specific questions that we raised.
Thanks, Emily. I'm going to first present data to first address some of the common challenges related to the test interpretation and use, and then talk about the clinical implications of a semi-quantitative test. So how do the quantitative thresholds for G6PD classification align with case definitions and G6PD activity distribution? Next slide, please. So this is a schematic showing the G6PD phenotype and genotype. Because G6PD is an X-linked genetic disorder, males can be either homozygous G6PD deficient or normal by phenotype. On the other hand, females can be either homozygous or heterozygous for G6PD, and therefore exhibit a broader range of deficiencies depending on the random inactivation of one of the 2 X chromosomes. Males with a deficient G6PD allele and females with 2 G6PD deficient alleles typically have a G6PD activity of less than 30% of normal, shown here in red. Males with a normal G6PD allele and females with 2 normal alleles tend to have G6PD activity that follows a normal distribution around the 100% median, shown in green. Heterozygous females, shown in yellow, with 1 normal and deficient G6PD allele can express a range of G6PD activity ranging from less than 30% to greater than 70%, with the majority falling in the intermediate range between 30 and 70% activity. Next slide, please. So what is the expected precision of the point of care test? Next slide. Expect variability in the point of care testing. A fingerstick precision study was conducted in a clinical lab in Florida to investigate the variance in G6PD measurements from fingerstick samples. 15 healthy adults were recruited as follows: 5 deficient individuals, 5 intermediate females, and 5 normal individuals. Upon enrollment, fingerstick capillary samples were collected and tested with the standard from 2 fingers on one hand and 2 fingers on the second hand, generating 8 measurements of G6PD activity per participant. Next slide. This figure illustrates the results of the study. The standard G6PD activity is shown on the y-axis, and the study participants are on the x-axis. For each participant, the gray dots represent the repeated measures, and the red line is their average. According to the reference assay, mid-5 is actually a normal with 93% G6PD activity. So the results indicate that repeatable results were observed for G6PD deficient and normal study participants, and most of the discrepancies observed were among the intermediates. Also, there is greater variability as G6PD activity increases, and some variability will result in test results that cross over thresholds used for semi-quantitative G6PD status classification. Next slide, please. This table shows the breakdown of the Fingerstick precision study results between the reference and the standard test. For all 5 deficient participants, all results, 40 out of 40, were consistently below the threshold for G6PD deficiency. Among the 6 normal participants, only 3 out of 48 results were discordant. And among the 4 intermediate participants, 7 of the 32 results were discordant. 2 of these results were below 4 on the standard, and the remaining 5 were above 6. The 5 false negative results were from female samples, mid 1, 2, and 3, that had greater than 63% reference activity. Next slide, please. Is it necessary or useful to establish site-specific thresholds for standard G6PD test results? Next slide. So these figures show the median and interquartile ranges for normal males across several sites. The figure on the left is for the point reference assay from venous blood, and the one on the right is for the standard test for venous and capillary blood. As shown here, there is a lot of variability in the reference assay, but not on the standard for both capillary and venous samples. Next slide. Hence, per the new standard label, we recommend that sites not determine their own thresholds, as the thresholds listed in the IFU have been validated and optimized across multiple sites and studies with over 4,500 specimens from 5 countries. Moreover, G6PD values and thresholds determined on a different assay will not apply to the standard G6PD test. And thresholds should only be established by qualified laboratories using best practices. But this is not recommended, as it would be considered an off-label use of the test. Next slide, please. Interpreting test results. Are there intermediate males? Next slide. This is a histogram generated from males from venous samples using the reference point scientific assay from clinical data from the US and Brazil studies that are going to be published soon. Frequency is on the y-axis, and normalized point G6PD activity is presented on the x-axis. As expected and consistent with G6PD epidemiology and the schematic presented earlier, we see the bimodal distribution in males. However, there are few males in the intermediate range, between 30 to 70% G6PD activity, and this accounts for about 1.6% of all males. Next slide. These histograms are for the same males, but generated from capillary and venous samples using the standard test. Here we see in the histogram using standard capillary samples, 9.9% of all males are in the intermediate range. In the histogram generated from standard venous samples, there are 7.6% of males in the intermediate range. So the reason why we see a higher percentage of intermediate males with the standard test as compared to the point scientific reference assay is largely due to imprecision and narrower dynamic range of the standard test from 0 to 20 as compared to the points reference assay that has a range of 0 to 30. So the main takeaway here is expect to see males in the intermediate range on both the standard and reference test. And secondly, to date, all intermediate males have been confirmed G6PD normal by reference assay or genotyping, with the exception of one individual from the US that was deficient by genotype, but normal by enzyme reference assay, specifically A-. Next slide, please. Understanding the clinical implications of a semi-quantitative test, performance, and treatment. Next slide. So this is a dot plot of standard capillary samples for males from US and Brazil studies. The point scientific reference percent G6PD activity is on the y-axis, and the standard semi-quantitative classifications, deficient and normal categories for males is on the x-axis. The gray dots represent males who are intermediate between 4 and 6 on the standard test. This dot plot shows that there's a wide range for normal males, but since all normal and intermediate males have a G6PD activity of greater than 30% activity on the reference assay, males in the intermediate range are normal. Next slide. The standard test overestimated the number of G6PD deficients. This is represented by the yellow box. At 30% threshold, among 930 males classified as normal by the reference test, only 15 were misclassified as deficient by the standard test. But the standard did a really good job in discriminating between deficient and normal at the 30% threshold, as shown by the green box. Hence, in the context of malaria case management, males who are classified as normal by the standard test could safely receive primaquine. As the standard test overestimated the number of males classified as deficient, these 15 males who would be eligible for primaquine according to the reference test would not be eligible for primaquine by the standard test. Next slide, please. The figure on this slide is a dot plot for capillary samples for females from the US and Brazil studies. Again, the point scientific reference percent G6PD activity is on the y-axis, and the standard semi-quantitative classifications, deficient, intermediate, and normal categories for females is on the x-axis. This dot plot shows that there is a wide range and overlap in all female categories. All normal females had a G6PD activity greater than 60%, and majority of the intermediate females have a G6PD activity greater than 70%. Next slide, please. Again, for capillary samples, the standard test overestimated the number of G6PD deficients and intermediates, as shown by the yellow and orange boxes. At 30% threshold, among 1,110 females classified as normal by the reference test, 26 were misclassified as deficients by the standard. At the 70% threshold, among 1,044 females classified as normal by the reference test, 71 were misclassified as intermediate by the standard. But again, the standard did a good job in discriminating between deficient, intermediate, and normal at the 30 and 70% thresholds, shown here by the green boxes. And only 5 intermediates by the reference test were misclassified as normal by the standard. Hence, in the context of malaria case management, females who are classified as normal or intermediate by the standard could safely receive primaquine. Because the standard test overestimated the number of females classified as deficient and intermediate, these 97 females who would be eligible for Primaquine according to the reference test would not be eligible for Primaquine by the standard test. Next slide, please. So based on the case definitions Emily presented earlier, and in the context of malaria case management, all males who test in the intermediate or normal range by the standard test have greater than 30% G6PD activity on the reference assay, and therefore can be classified as G6PD normal. And in the context of malaria case management, receive Primaquine treatment as per recommendations. For females, Primaquine would be recommended for those classified as normal or intermediate by the standard test. It's important to note that the standard thresholds are conservative, as seen by the overestimation of deficient and intermediates for men and women across sample types. The clinical implications for this subset is that based on these treatment guidelines, they would not be eligible for Primaquine according to the standard test, even though they would likely be eligible if tested by the reference test. But it is imperative to weigh the risks and the benefits of providing Primaquine treatment for women who are classified as G6PD intermediate. There is some misclassification of females who are normal by the standard test, but intermediate by the reference test. However, these females have a G6PD reference activity above 60%, are within the variability of the reference assay for G6PD activity, and represent a relatively small proportion. Next slide, please. And I believe I hand this back to Emily.
Yeah, thanks so much, Pooja. So I think to really understand the impact of how, the impact of this test on clinical case management, you have to look at a country to understand how access to the test would change access to radical cure. And so we need to look at the algorithms, the diagnostic and treatment algorithms, both before and after the use of the test. And just to kind of put it in perspective, I thought it'd be useful to give this example from Lao PDR. So prior to using a quantitative test, when there was some use of a qualitative RDT, the recommendations were to screen only Vivax positive men with a qualitative RDT and then treat normal men with standard Primaquine treatment. The recommendation was to not screen women with the qualitative test and instead treat them as presumed G6PD deficient. Just presumed G6PD deficient or intermediate, which in Lao meant not giving them Primaquine. Through an operational research study that PATH and the Malaria Control Program and UCSF have been collaborating on, we introduced the semi-quantitative standard test, and with the use of that test, under this research protocol, changed the treatment and diagnostic algorithm to screen both men and women, and then treat everyone who tests as G6PD normal with the standard Primaquine treatment. And so if you go back to Pooja's dot plots, just based on this illustrative data from sites in the US and Brazil, that there may be some overestimation of deficiency by the standard test, but its use in this setting actually sort of opened up and enabled access to Primaquine treatment for this whole swath of G6PD normal women who were previously not screened and not treated. So I think it's useful just to look at the sort of big picture of how the test will actually impact case management. Next slide. And so just again, to call back to a few new resources that have been made available. So we have developed this job aid, which is on the GORCOP resources page. And in addition, we've started to develop a frequently asked questions page where we've answered questions that we've gotten over the course of the last several months, and addressed some to do with the performance of the test, which Pooja has addressed today, but other questions, more around ordering and things like that. And those questions and answers are on that FAQ page. Next slide. Yeah, so just to thank everyone. PATH has had so many excellent collaborators over the last several years working on this project. And then specifically, thanks to all the study participants at the sites in the US and Brazil, Washington, Pennsylvania, Portobello, and Manaus, who contributed to these data, and in addition, all of the field lab and data entry teams at our partner organizations. Without all their work, we wouldn't have these data to kind of help explain some of the nuances of the use of this test. So thanks so much to all of them. Next slide.
Thank you very much, Emily. Yeah. So thank you very much, Emily and Pooja, for the wonderful presentation. And before I proceed further, I would like to remind about the part 3 of the GOCOP webinar. So it's in June 2nd, that is 7 AM BST, which is 1 PM ICT timings. It's on multi-lab assessment of the repeatability and reproducibility of a G6PD, of a quantitative G6PD diagnostic, which is the standard G6PD test. The speaker is Dr. Benedict Lay from APMEN VIVAX Working Group and Menzies School of Health Research, Australia. As I open for the questions, firstly, I would like to thank all the participants who participated the PATH survey on standard test result interpretation. There are two most asked questions, and I would request Emily and Pooja to take them first. They are, for number one is, what does it mean when the G6PD activity says high instead of a number? And the second is, should I use the G6PD test results if the hemoglobin result is less than 7 grams per deciliter? So over to you, Pooja and Emily.
Thanks, Abhijit. I'm going to take this first question as to what does it mean when G6PD activity results as high instead of a number. I first wanted to say that high is not an error when you get it. It's actually an indication that G6PD value is outside the measuring range, usually above 20, and therefore the high really can't be interpreted as a normal. I think we can move to the next question.
Yeah, great. So we had a couple of different questions around the relationship between the G6PD activity result and the hemoglobin result. And just to outline, the hemoglobin measurement is used to normalize the G6PD activity, which is given as a number of units per gram hemoglobin. So they are dependent on each other. And one thing you'll note is that, or you may have noted, is that when the total concentration of hemoglobin is lower than 4, you'll see a little low for the hemoglobin result, and then the G6PD activity will read as NA. And similarly, if the total hemoglobin concentration is higher than 25, you'll see a high instead of a hemoglobin result, and the G6PD activity will read as NA. Next slide. And so there is this sort of strange gap where the product label recommends that if the hemoglobin result is lower than 7, that the G6PD test result is not used. but the G6PD activity will still show up on the screen. So I think it's just an important thing to flag for people. And so should you use the G6PD test result if the hemoglobin result is less than 7? No, not according to the label. And recommend that, of primary importance is probably to resolve the low hemoglobin level, and this may warrant retesting as 7 is quite a low hemoglobin concentration. And so again, according to the label, would recommend retesting or performing a confirmatory test. Next slide. And yeah, just to reiterate Abaji's thanks to everyone who contributed questions and responses to the survey. We did get some clear directions about what new resources are needed. So I just put on this slide the most commonly cited requests, and I think we'll work on developing some of these in the next few months. Thank you.
Okay. It is a time if you can raise your hands if there is any questions from your side, please feel free.
And Abhijit, I think there are actually quite a few questions that have come in over the course of the presentation in the chat box as well.
Yeah. I can take them first. The question coming from Anlapa Rubsung, it's for Emily. Is mentioning that they have observed that the biosensor is overestimating the HB level when compared with the actual hemoglobin analyzer. So wanted to know if you also experienced this phenomena when performing the test. Emily.
Yeah, so I'm actually gonna to punt this question to Pooja, who worked more closely on this analysis. And others from the PATH team, I know Shampa and Gonzalo are also on the call, so also feel free to chime in. Oh, and Steph.
Yeah, I'm just going to take a stab at it. So yes, we have looked at hemoglobin levels, and I do not think that the standard test overestimated the hemoglobin levels when compared to the actual analyzer. I don't know, Shampa or Steph, if you're on the call, if you have anything to add, but I don't believe I observed this phenomenon.
Can I go to the next question, please?
Sure.
So, yeah, the next question is from Evelyn Wong. For the finger prick test, was there any genotyping to understand whether those within 4 to 6 are true intermediates or not?
If you want, I can step in for that one. We've done limited sequencing of the samples in these studies, and we did try to include in the US study sequencing of samples between 4 and 6. I can't say that the females in the precision study were including in there. They should have by the criteria, but it also depends on the consenting. And what we saw is what we presented on the last webinar, which is you primarily do see heterozygous in that region, but females, but there are some homozygous females creeping in, especially above 60% activity. So those 3 women or 4 women with activities close to 60% were likely to be heterozygous, but could have also been homozygous based on the sequencing we had, the limited sequencing we've done in these studies.
Thanks, Gonzalo. The next question coming from Hu again. Any different in interpreting G6PD semi-quantitative test in children? mainly male and female children versus adult that wants to know.
So we did have some children in our study, but honestly, we did not slice and dice this, our analysis by children versus adults. We haven't looked at that yet, but I would imagine that interpretation would be the same for children.
Thanks, Pooja. The next question coming from Ari Satyagraha wants to know if SD biosensor can be used in newborns also.
I'll take that and actually put someone else on the spot. The label does not include newborns and actually explicitly says that it has not been validated in newborns. I think Germana can talk a little bit more though to experiences with newborns and also any concerns around children and versus adults, and I think David Roper would also be well positioned to talk to that.
Yeah, can you hear me?
Yeah.
Yes.
Yeah, so we are currently running a validation study on newborn, and obviously the main point is the newborn have increased activity. So basically what we are observing is that all the thresholds are shifted to the higher level. And so far, the biosensor used by midwives seems to work okay, but we haven't finished the validation yet. But I would say that definitely the deficient can be really clearly identified. And the intermediate as well, although we don't have that many yet. But unfortunately, the threshold between intermediate and normal, it might not be very clear. So we need to finish the sample collection, and we'll know more about that.
Okay. Thanks, Germana. So the next question comes from you to Pooja. Would you like to ask it or should I go? Okay.
I can ask it directly. It's actually because we've been using the high as an invalid result so far, but we only observed it in the field. We never seen it in the lab, and we don't have the reference test done on the same sample. So I was just curious to know if you have a number of samples that you could analyze for the reference and with high result in the biosensor that would really confirm that they are high and we can actually say they are normal. Thank you.
Yeah, Germana, I believe we do have high spectral results from greater than 20, and given some of the field high samples did come in, so we do have some of that data to validate that it really does correspond to greater than 20. What we've done when we've gotten a high result in the field, we've just recoded them as 20.1 and continued with the analysis.
Okay, thank you. That's really good to know, actually. Thank you.
Thanks, Germana and Pooja. So the next question comes from Jane. She wants to know that given the variability and misclassification of normal patients as deficient or intermediate, what do you think are the appropriate conclusions to make with results of standard G6PD? Is confirmatory testing recommended for deficient and intermediates? If confirmatory tests not available, how are countries you have worked in counseling patients?
I could try and answer this one, and then would welcome any input from the rest of the team. But I think it's a really good question. I think that one of the things that we're seeing is potential limitations around what you would be able to say to someone in terms of their G6PD genotype at the point of care. That's not what this test can tell you, but I think it can tell you reliably someone's G6PD status at the point in time in which they receive a diagnosis. So I guess I would just say that I think counseling messages would need to be kind of carefully crafted to really speak to like what's relevant to the patient at that point in time and what the test can tell you. I don't know if others have any thoughts on that.
Thanks, Emily. So the next question comes from Vanlapa, who's interested to know about the high dose PQ. So as there's a talk on the 14 days low dose PQ, which she thinks is the case RDT is good in discriminating the G6PD deficiency for treatment and also more cost effective. Should the speakers touch a bit on the high dose PQ? Can expert in the field discuss on the outcome of providing high dose PQ in intermediate females?
I can take that. And I don't know if what you're referring to is the 7-day high dose PQ, but if that's the one, we haven't generated any data on that, and I think that's better for the teams that have been working on that to respond to that. We certainly don't have any information around the high dose and the implications of that on the safety thresholds.
Okay. So next question comes from Nonkozo. Wanted to know if you can talk about why hemoglobin greater than 25 shows G6PD result as not applicable, and what's the risk in treating these patients with primaquine?
I think it. I'm not. I can't confirm this is the correct answer, but those ranges are based on linearity and demonstrating that the device can measure in an analytical experiment hemoglobin within those ranges. So outside those ranges, then there isn't a lot of certainty on the hemoglobin activity. So because it's the denominator in the final result, it would be inaccurate for the instrument to provide a G6PD normalized by a hemoglobin value that is not measured within what's been demonstrated to lie within the linearity of the device from an analytical perspective. And sorry, what was the second part of the question?
What's the risk in treating these patients with primaquine?
I can't answer that question. I think because you don't have the G6PD value, then you're in the other scenario where you're making the risk benefit assessment. So that will be on a case by case basis.
Okay, thanks, Gonzalo. So Yushen Sai got a question about if US and Brazil data can be applicable to other countries too, mainly to identify if men having G6PD level between 4 to 6 are normal or not.
Yes, the data from US and Brazil is applicable to other countries, and especially if, as our data has shown that we presented today, that all males that had G6PD levels between 4 and 6 on the standard are really normal. And so we believe this will translate to other countries.
Thanks, Pooja. Second question coming from Jane is all references have been on using the test to guide standard dose primaquine administration. So do you think the profile of intermediate female misclassified as normal will be acceptable to guide administration of tafenoquine?
I think at this stage we can't answer that question. No MMB is conducting studies to assess that.
Great. So the next question is coming from Doomtham. Its G6PD test result is very important to continue treatment for Vivax patients with Primaquine in Vietnam. Do you need to calibrate the G6PD machine frequently? If yes, and then how long to do it once?
So I'm not sure what's meant by calibrate. If the person who has the question could clarify a bit.
Yeah, if Doom, can you clarify this one once? Should I repeat the question once more?
Sorry, maybe I can add. There isn't a mechanism for calibrating the machine. There's a check strip to ensure that it is actually functioning, and there are control reagents that you can use to again verify that the assay components. But there at the moment there isn't a mechanism for calibrating the G6PD machine outside. The calibration is done on the assay strips on a lot by lot basis to ensure that they're consistent between lots. And that's why each kit comes with a chip that provides those calibration parameters that are specific to that kit of strips.
Thanks, Gonzalo. And I can see some exchange between Jane, Jamana, and Ari. So is there any question for the speakers, or this is the last one? Okay. So I think that's all questions that we have received till now. Okay. Thank you again, Emily and Pooja, for answering those questions and for the great presentation. It was a pleasure to have you all with us. And I don't think any more questions coming up. So yeah. So I'm concluding this webinar for today, and thank you all for attending.
Thanks, Abhijit.
Thank you, Abhijit. Thank you, everyone.
So